class, in this lecture, we will review drug interactions. Drug interactions can occur with other drugs, including over-the-counter drugs and complementary and alternative medications, or with food. So we'll talk about all the different ways drug interactions can occur. The objectives are listed on the slide, and they're also in your Blackboard module. Pertinent vocabulary terms are listed. You can find the definitions in your textbook. Drug interactions can occur anytime more than one drug is taken, and they can impact the magnitude of effect as well as the duration of effect of another drug. Some drug-drug interactions are intended. For example, probenecid is a drug that can be given with penicillin. It delays the excretion of penicillin, prolonging its therapeutic effect. It's technically a drug interaction, though, because probenecid prevents the renal secretion of penicillins into the urine. But it is a drug interaction that is beneficial. Back in the, 60s or 70s, this was a drug interaction that was taken advantage of because back then penicillins were pretty expensive. And so probenecid would be given along with penicillins to decrease the amount of penicillin that was needed. Truthfully, nowadays we don't really capitalize on that drug interaction anymore because penicillin is very cheap. But nevertheless, good example of when a drug interaction can produce a desired effect. Most drug interactions, however, are not intended, such as when metronidazole, which is an antibiotic, interacts with warfarin, which is an anticoagulant, and this drug interaction can lead to serious bleeding. So it's important to recognize that interactions can occur when a new drug is added and the patient's already taking something else that that drug can interact with, or when a drug is discontinued. In many cases, the latter is overlooked, unfortunately. So for example, I mentioned that metronidazole is prescribed for a patient taking warfarin, and if we don't do something about that, the patient could experience bleeding. So generally, we preemptively reduce the warfarin dose by about 50%. And this takes some monitoring and adjusting until we figure out the exact dose that's appropriate for the patient. But metronidazole is an antibiotic, and it's not usually used for more than a week or so. So when that metronidazole is discontinued after 2 weeks, there's going to be a need to go back and change the warfarin dose back to its previous dose. So that's what I mean by when a drug is added, there could be interactions, or when a drug is discontinued, there can be changes as a result of those interactions. And so this is something to keep in mind. These interactions that occur when a drug's removed from the therapeutic regimen don't always get addressed. And I'll talk about some examples throughout this lecture. The consequences of drug interactions, as I said, can be either therapeutic or adverse. One drug may potentiate or intensify the effects of another, and again, those could be increased therapeutic effects or increased adverse effects. One drug could reduce the effects of the other drug, and again, it could be either reduced therapeutic effects or reduced adverse effects. And then kind of a third thing that could happen is that one drug combined with another drug could produce a completely new response that's not seen when either of those drugs is used alone. So for example, alcohol, which we would consider a drug, it's a therapeutic substance, right? So when alcohol is used along with a drug called disulfiram, the other name for disulfiram is Antabuse. Antabuse is actually used to treat alcoholism. And when these two are taken together, it causes a very unpleasant constellation of effects. The patient is very uncomfortable, they're flushing, they're sweating, their heart beats really fast. None of these effects are seen with either just the alcohol by itself or just the Antabuse or disulfiram by itself. So now, as I said, this is actually a desired therapeutic effect. We use this drug specifically to help patients not continue to drink alcohol. So this drug is used for alcohol use disorder because it keeps the patient from relapsing into alcoholism, because they know if they drink while or drink alcohol while on a disulfiram, it's going to produce a really uncomfortable physical response. So let's talk about the intensification of effects first. So I mentioned that there could be increased therapeutic effects, and I think we in many cases would say that's a good thing, right? So if we have a better therapeutic response, then that's a good thing. So some examples of when we increase therapeutic response. So ampicillin is an antibiotic that is sometimes combined with sulbactam. Sulbactam is a drug that helps prevent bacteria from becoming resistant to ampicillin. So it boosts the therapeutic effect of ampicillin. Again, I think we would all agree that's a good thing. Protease inhibitors are drugs that are used for patients with HIV infection or Hep C infection. And so protease inhibitors are able to boost the activity of other HIV drugs, and that is a good thing because it allows us to use lower doses of those drugs. And so it's actually called protease boosting. So again, that's a good thing. Now, sometimes the good comes along with the bad. So for example, those protease inhibitors that are effective at boosting other HIV drugs, they can also lead to drug interactions. So when those protease inhibitors are used with other drugs whose effects they also boost, they can cause such an incredible increase in therapeutic effects that the patient actually begins to experience adverse effects as a result of that increase. So all of this is a bit nuanced. In one situation, the effect might be good, but if that, sometimes too much of a good thing is not so good. So keep that in mind. We can also increase adverse effects, and I think we would, all agree that's a bad thing. So for example, aspirin and warfarin both affect the bleeding cascade, or the clotting cascade, I should say. And so when used together, they can lead to excessive bleeding because they act on different parts of hemostasis. Benzodiazepines, which are used for anxiety, so Xanax, some of you may have heard of, but when these are combined with opioids, they can cause excessive CNS depression that actually can result in death. So again, increased adverse effects, examples of where that's bad. And in general, we would say increased adverse effects are a bad thing. Reduction of effects. So these can either be reduced therapeutic effects or reduced adverse effects. So again, these are interactions that result in either one or both of the drugs having less effects. So they have decreased activity, and that activity could be either in the realm of therapeutic activity, or it could be a decrease in causing specific adverse effects. So once again, when we talk about reduced therapeutic effects, this is the opposite of what we talked about on the last slide. I think across the board we would say that's a bad thing. So propranolol and albuterol. So these are some of the first drugs that we'll talk about in this course. These drugs are beta blockers. So propranolol is a beta blocker. It blocks beta receptors in the heart and in the lungs and in other parts of the body. Albuterol is a beta agonist, so albuterol activates these receptors. So clearly, when you use these two drugs together, they can kind of offset the response, either the response of the propranolol or the response of the albuterol, and either way, that could be a bad thing. Calcium and antibiotics, another example. And so calcium, in some cases, binds antibiotics in the GI tract and prevents them from getting absorbed into the bloodstream. And so clearly, if the drug can't even get into the bloodstream, it's not going to be able to exert its therapeutic effect. And again, we would all say that's a bad thing. And then reduce adverse effects. So again, I think if we say adverse effects go down, then that's going to be a good thing. A great example of where we purposefully give drugs together to reduce adverse effects is when we use naloxone or Narcan to treat morphine overdose. These two drugs act at the same receptor, and naloxone blocks those receptors, morphine activates those receptors and causes decreased response to pain, but can also cause respiratory depression. So when we give naloxone along with morphine, it can decrease or reverse respiratory depression that the patient is experiencing. And I already explained the situation of using alcohol with disulfiram. So the basic mechanisms. So you all may be thinking, okay, so I've heard some consequences of interactions, but how do they occur? What is going on? And I know a lot of you like to understand the why of things in order to help you kind of process how things occur. So I'm going to go through the basic mechanisms of drug interactions. They fall into 3 categories: direct chemical or physical interactions. Nurses are very important at preventing those. We'll talk about those in a moment. Pharmacokinetic interactions and pharmacodynamic interactions. So in terms of chemical or physical interactions, these occur because some drugs will either chemically combine or interact, I should say, with other drugs when they are together in a solution, maybe because they're in an IV line or they're in a beaker, whatever. So they may chemically interact. I think what we see more frequently, though, are physical interactions. And so with these physical interactions, say you're administering 2 medications in an IV line, and sometimes we do that because we don't have enough ways to get the medications into the patient. And so if those 2 medications are not compatible, then you might see a precipitate, like what you see in this picture. You see that there's kind of like a little snowflakes or little chunks that occur in the IV line. This is a terrible, terrible thing to happen. Sometimes it causes the line to be completely replaced. So take-home message: never combine medications in an IV line. I mean, generally that's an avoided practice, but sometimes you don't have other options. But you never combine them unless you know that it's safe to do so. Because sometimes you can see the precipitate, like what you see in this picture, but sometimes you can't see it. It occurs, on kind of a micro level, and even though it's not visible to the naked eye, it could be a large enough precipitate, especially in neonates and very small children, that it could cause a blockage in the patient's heart or lungs, and that can be life-threatening. So this is very serious, and it's almost exclusively up to nurses to manage this interaction. Now, the good news is, if you're not sure, you can call the pharmacy. Pharmacy can give you some additional information and look stuff up and let you know what your options are. But bottom line, you need to check into this prior to administering the medication. Now we'll move on and discuss pharmacokinetic interactions. Remember, pharmacokinetics consists of absorption, distribution, metabolism, and excretion. So first we'll talk about pharmacokinetic interactions that affect absorption. So these types of interactions can either increase or decrease the extent of absorption. And if you think about that, either of those can be a problem. If you increase absorption, that could mean that too much drug, more than what normally is absorbed, is able to get into the plasma and get to the site of action. And if more drug gets to the site of action, then more drug has the opportunity to produce a therapeutic effect. Now, frankly, we don't see a whole lot of examples of that. What we tend to see more frequently is a decrease in the extent of absorption. And so again, if the drug's not absorbed, then that means it does not get into the bloodstream. And then of course it doesn't get to the site of action, and it's unable to produce a therapeutic effect if it doesn't get to the site of action. So these are very serious. You have to understand this mechanism. And the reason why is, as a nurse, this is another type of drug interaction that nurses are almost exclusively going to be managing, especially in the inpatient setting. I can tell you as a pharmacist, when I would encounter absorption type interactions, I personally would usually contact the nurse and make sure that they understood it and knew what to do. But my colleagues would almost never do that. They just assume that nurses are familiar with these interactions and take appropriate action to manage them. So please pay close attention on this part. Now, they can occur by a variety of different problems. So it could be that the gastric pH is increased, and that either causes an increase or decrease in the amount of drug that's absorbed. So for example, we're going to talk about the azole antifungals later on in this course. Itraconazole, voriconazole, ketoconazole, fluconazole, these are all azole antifungals. And they have pH dependent absorption, especially itraconazole. And so they need a low pH to be absorbed. But if you give a patient antacids, that's going to cause the pH to go up, and that's going to influence the amount of drug that gets absorbed. And those drugs are antifungal drugs, and I think many of you know fungal infections are really serious. So we could see treatment failure as a result of these interactions that could be life-threatening. Other things, laxatives, they can cause drugs to rapidly go through the GI tract and they won't get absorbed. Some drugs slow peristalsis and that will increase absorption. Some drugs induce vomiting, and so if you take a medication and then you vomit, well, then that medication is probably not going to be absorbed to an appreciable extent. So again, it's going to influence absorption, usually decrease absorption. Adsorbent drugs. So this is another really important one. Circle this. This is extremely important. This is probably, I think, what you guys will see most frequently. Adsorbent means that two things are binding together. So one drug is going to bind another drug. I mentioned in the beginning of the lecture calcium. Calcium frequently binds other drugs. And when they bind together, neither gets absorbed because the molecule is so big at that point that it's difficult to get absorbed, or other factors prevent it from being absorbed. And so my example previously was antibiotics. Imagine if those drugs don't get absorbed, imagine how that can impact therapeutic effectiveness. And then some drugs will decrease blood flow, and that's just another mechanism. So put a star on this slide. This one's really important. You definitely need to know this for the exam. So next we'll talk about distribution. And when we talked about pharmacokinetics, I talked extensively about protein binding. So some drugs alter the distribution of drugs from the blood to the site of action. And so protein binding is probably the best example of this, although it can happen other ways as well. And so you may remember this picture. I showed you this previously. Albumin is the most common protein that's found in the plasma, and it has a high propensity to bind drugs. So remember, those little black circles, those are medications. And so in this example, we've got a medication that is binding to albumin. But let's say another drug comes along and has a higher affinity for protein, for that particular protein, and it kind of knocks the other drug off of its binding spot. Well, remember, what'll happen is that your bound concentration goes down, and then the concentration moves to the right. You've got more free drug. If you've got more free drug, that means more drug is floating around in the plasma, and that means more drug will get to receptor sites, and that potentially means an increase in therapeutic response as well as potentially adverse effects. Now, protein binding is, protein binding interactions are more important for drugs that are highly bound. So if a drug is 90% bound and just a small fraction of that becomes unbound, you could go from 5%, for example, to 10%. But if you think about those raw numbers, that's a 100% increase in the raw amount of free drug. And so that could be a 100% increase in your therapeutic effect or your adverse effect. So it's highly bound drugs that we worry most about. When we talk about antiepileptics, we'll talk about a drug called phenytoin, and that's probably one of the most prominent examples. The good news is these interactions occur, but the body's pretty good at dealing with them. Usually it takes the body a day or so to address this, and so the body will just start to excrete more of that free drug. But where patients get into trouble is if their kidneys aren't working, or if however that drug's excreted, if there's issues with that, maybe there's liver issues. So that's really where patients get in trouble, or if the drug has a narrow therapeutic index like phenytoin. So the third type of interaction I want to talk about are interactions with metabolism. This is by far the most important, and unfortunately the most complex type of interaction that we see in clinical practice. This type of interaction is related to the CYP P450 enzymes primarily. So we talked extensively about these in our pharmacokinetic lecture, but you may remember the CYP P450 enzymes are a group of enzymes that metabolize drugs. Now, they can metabolize drugs in a variety of different ways, and what I mean by that is the consequences. So they usually metabolize drugs to more polar metabolites that are able to be excreted. That's not always the case, but the majority of times that's what we see. So you can imagine if something interferes with that metabolism, that can impact drug levels, and that of course can influence therapeutic response as well as adverse effects. So we have two categories here, and I have a little mnemonic to help you remember these. So inducing agents. So there's a C in inducing, and so we think about, well, what happens when certain drugs induce these CYP enzymes? It causes the metabolism of other drugs to increase. So easy way to remember this is CC, right? So C in inducing and C in increase. And so inducing drugs will increase the metabolism of other drugs. And then subsequently, we will need to increase the dose of the other drug. So the drug that's impacted. Not the drug that's causing the induction, the drug that's being influenced by that other drug. So CC, great way to remember that. Inhibiting agents. So my mnemonic for that is BD. And by the way, CCs is another way to say mLs, right? And BD are the most common syringes that you're going to see. You may not know that yet, but trust me, in your careers as nurses, BD syringes are super common. So that's how I always remember this, CC and BD. So inhibiting has a B in it, and decrease starts with D, right? So drugs that inhibit, drugs that are inhibitors will inhibit the metabolism or decrease the metabolism of other drugs. And in that case, because the drug levels will rise, we're going to need to decrease the dose of that other drug. So this is just a very basic description of what's going on. I think what I want you guys to all take home from this is that we have inducers, and I have the most important examples listed on your slide: phenytoin, phenobarb, carbamazepine, and rifampin. Circle those, put a star next to them. I want you to know them. Inhibiting agents, these are drugs that will decrease metabolism, so BD, inhibitors, decrease metabolism, so we need to decrease the dose of that other drug. Examples of inhibitors: protease inhibitors. How nice is that? The name tells you that it's an inhibitor. Protease inhibitors, azole antifungals, cimetidine, which is a drug that's used for GERD, and erythromycin and other drugs that are similar to erythromycin. So these are some of the most prominent examples of inhibitors, so I think you should know those as well. And the idea here is when you are administering medications and you go to your MAR and you see that you're going to give phenytoin, I want you to stop and think, wait a minute, this is one of those drugs that affects the metabolism of other drugs. I need to make sure somebody's done something about this. So I would want you to have that thought process across the board. Your book goes into a lot more detail about this. What I have on the slide is like keeping it simple. This is, the basics of what you need to know. So don't get caught up on this with everything all that detail that's in your book. If you want to have discussions about it, I would love to. This is one of my favorite topics to talk about. So, you could always come talk to me, or you post a discussion question on the discussion board, and we can go into all kinds of detail about this. But in terms of what we expect you to know for your exam, what I have listed here is what you need to know. Okay, so moving on. The last type of pharmacokinetic interaction is excretion. And so one of the areas of excretion in particular that can be influenced by drug interactions is renal secretion. So remember, when we talked about excretion, we talked about filtration that occurs in the glomerulus, we talked about reabsorption, and we also talked about active secretion. So frankly, drug interactions can occur at any of those steps. However, what we see most frequently is secretion. So one drug influences the secretion of another drug. And that's about all I'm going to talk about that. The third type of mechanism that underlies interactions are pharmacodynamic interactions. Remember, when we talked about pharmacodynamics, we were talking about the activity of the drug at the receptor, so what the drug does to the body. So all of these types of interactions are going to be related to activity at the receptor. They're not going to be related to ADME or the absorption or distribution or metabolism or excretion. Those were all of our pharmacokinetic interactions. These are going to be really related to the effects of the drug, specifically at the receptor. So one drug is going to alter the effects of the other drug, and that could be additive. So we might see excess response, so therapeutic response. That might be good. Usually, in most cases it is. Some cases it's not. Or it could be increased toxicity. And I know you guys all can imagine there's like no examples of where increased toxicity would be a good thing. That's always going to be a bad thing. So an example of additive toxicity I already talked about was when I said benzodiazepines used along with other CNS depressants like opioids or antihistamines or alcohol. These can cause excessive drowsiness, or they can even lead to respiratory depression. So that would be very concerning. In terms of antagonistic, so this is where we see a reduction or a blocking of the effects. And again, it can be either therapeutic or toxic. And so I mentioned some examples before, but just to highlight this again and help you think through it, I think a good example where we see a reduction in adverse effects or toxic effects is when we use ACE inhibitors. I'm sorry, not ACE inhibitors. When we use two different types of diuretics together. So when we talk about hypertension and heart failure, we're going to talk a lot about diuretics. But one of the things that happens with diuretics is that electrolytes are lost, specifically potassium, and this can be a big problem. So to reduce that effect, we sometimes use two types of diuretics together. A thiazide diuretic or some of the other kinds of diuretics along with a potassium-sparing diuretic. So what happens is they offset the effects of potassium. So thiazides, for example, cause a loss of potassium. The K-sparing diuretics cause a retention of potassium. And so the net effect is that there's no difference in your potassium level. So you can see that those two drugs antagonize those adverse effects. If you use either one on its own, potassium-sparing diuretics by themselves, you see an increase in potassium. Regular diuretics, you see a decrease. So they kind of antagonize those effects, and the net effect is, a good thing. So just an example. And then finally, combining toxicity at the same organ. So this is a little different from the examples I just talked about, because what we're talking about here is the drugs are working kind of through totally separate mechanisms. They, have therapeutic effects, usually in many cases that are totally different. Sometimes they're similar, but usually they're totally different. But what we're really focusing in on is adverse effects, so toxicity, but specifically at the same organ. So, for example, isoniazid and rifampin, these are drugs that are used to treat TB, which is tuberculosis. The problem is they're both toxic to the liver in different ways. They're both toxic to the liver. So, normally we try to avoid drugs that are toxic at the same organ, but sometimes we have to use them together. So, and that is true for TB. Isoniazid and rifampin are two of the most effective drugs to treat TB, and because of the tuberculosis bacteria, because of the way it grows, we have to use more than one drug to effectively treat it. So isoniazid and rifampin are frequently used together, but there needs to be intense monitoring of liver function to prevent liver toxicity. So there's lots of other examples. Two drugs could be both be toxic to the kidneys or the heart, or the hematologic system. Pretty much any part of the body. Two particular drugs, if used together, could potentially be toxic there.
Let's talk quickly about drug-food interactions. These are both important, but they're also poorly understood to a large extent just because there's not a lot of research around these. Again, I think nurses are well positioned to identify and modify these reactions during drug administration. So when giving medications, especially oral medications, always thinking through, is there a relevant drug-food interaction that you need to consider? Here are some examples on the slide. Absorption that's either decreased or increased as a result of a drug-food interaction. So foods that are, for example, foods that contain a lot of calcium can interact with certain drugs. So like milk, for example, you should not give milk with tetracyclines because it will decrease the absorption and there will be no effect seen from the administration of that medication. Metabolism with certain medications, so grapefruit juice, for example, can inhibit the metabolism of many drugs, and sometimes the effect is quite remarkable and can cause some serious toxicities. Food itself can act on the drug. So for example, foods that contain a lot of vitamin K can decrease the effects of warfarin, a drug that acts by inhibiting vitamin K. And another thing for you to always think of when you're administering medications is timing. So you need to know whether specific drugs are okay to give with food, or do they need to be separated in time from food to prevent absorption problems.
Finally, let's discuss drug and CAM interactions. Now, I want to make sure before we talk about these CAM interactions that all of you recognize all of those drug interactions I talked about previously could occur with either prescription or over-the-counter drugs. I'm pointing out the CAM interactions because sometimes these fall off of people's radar. So clearly the conventional drugs certainly interact, but so do complementary and alternative medications. They're just as likely to interact as prescription or over-the-counter medications. But patients don't always appreciate that. So it's up to us to help them recognize that some of the CAMs they're taking can actually cause some serious drug interactions. Furthermore, there's not actually a lot of reliable information about the full extent of drug-CAM interactions because these drugs are not required to be studied prior to marketing. So that's another big issue to keep in mind. So some examples of known interactions. Probably the most important one is St. John's wort. You have to know that. So circle it or highlight it. This drug induces drug metabolizing enzymes, and it reduces the levels of many drugs. So remember before when I talked about metabolism interactions, I said that inducing interactions, remember they have a C in them, increase, which also has a C, so they're going to increase the metabolism of the other drug, and we're going to need to increase the dose of that other drug, again, because when we increase metabolism, it means that the blood levels are going to drop. So we need to give more of that other drug to have a therapeutic effect. This is a big deal. Patients don't realize that St. John's wort can do this. Maybe they're on an antiepileptic and then they have a seizure because the St. John's wort decreases the plasma levels of their antiepileptic, or their pain medicine, or their antihypertensive. The list goes on and on. So St. John's wort can be a big problem. Patients need to recognize that even though the medication's available at GNC or over the counter in the pharmacy, that it could potentially be a problem for other medications they're taking. Some other examples, ginkgo biloba, garlic, these are other CAMs that have known interactions. And frankly, there are hundreds of CAMs with known interactions. So I think the take-home point here is talking to patients about the possibility of CAM products causing drug interactions, but also when you are collecting a home medication history, don't expect patients to tell you about their complementary meds or even their OTC meds. You need to prompt for that information. You need to explicitly ask, are you taking any of these medications? And I would even prompt and say, look, I'm asking because they can interact with the therapies that we prescribe when you're in the hospital, and we need to know. So if you give them the why, for the reason that you're asking. If they're cautious to tell you because some people may not want to share that information, they may be more likely to tell you given that they know it could interfere with other therapies.
So clinically, drug-drug interactions can alter outcomes of drug therapy. But I do want you to take away from this lecture that that's not always a bad thing. Sometimes we use drug-drug interactions to our advantage clinically. Sometimes the drug-drug interaction is theoretical, but it's not clinically significant. Or maybe it could be significant in one patient, but not necessarily significant in another patient. Remember, there's a lot of genetic variation in patients, and that genetic variation, specifically for metabolism, can be translated into enzyme expression, which is, again, those enzymes are responsible largely for drug metabolism. So it wouldn't be surprising to see one drug that causes drug interactions in one patient may or may not cause those same interactions in another patient. In many cases, it's trial by error. We're looking at the patient, we're evaluating the medications that potentially interact, and sometimes we try them out and we see what happens. Obviously monitoring and waiting and seeing what happens is something that occasionally we'll do. As nurses, you must know that measures can be taken to minimize drug-drug interactions. Common sense would say the fewer the drugs, the fewer the interactions. So does the patient really need all the medications he or she is taking? If you know that two of the medications interact, kind of thinking through, are they both needed? Can one of them be eliminated? That is a reasonable thought process. Another really important aspect that I think nurses do a great job with is getting a good drug history. Asking about over-the-counter medications, which can be involved in drug interactions. Herbal medications. Remember, I talked about complementary and alternative medications. Patients don't always think to mention these when you ask what drugs they're taking. Make sure you ask in such a way that the patients will talk about these medications. Street drugs. Or illicit drugs. These also aren't always mentioned by patients. So finding ways to approach the topic so that patients are comfortable speaking about the medications that they've taken or even the illicit drugs that they've taken is important. Finally, another thing to think about, other people's prescriptions. Sometimes patients take their husband's medications or their children's medications or their parents' medications for a variety of reasons that we won't get into, but making sure that patients tell you that they're doing that so that you can assess for drug interactions with the meds that you're administering would be an important thing. So monitoring for drug-drug interaction effects of when you have a known combination is important. Identifying those reactions quickly and taking appropriate action to resolve problems, such as contacting a prescriber to potentially suggest a dose reduction, is an important responsibility of a nurse.
So this slide outlines some important patient education that you should share with patients to help them avoid drug-drug interactions. First of all, explaining to the patient why the medication is prescribed. That can help in a number of ways. But I'll tell you one way it can help is if they are in the pharmacy or in the clinic or even, being admitted to the hospital, they may not remember what drug they're on, but maybe they can tell you what it's for, right? And so, that can actually be helpful. You can say, well, my blood pressure medication or, whatever. And so not only is it good for them to know why they're on the medication, but it could also down the line prevent other problems. Clearly knowing how to take the medication. Do you take it with food or not? Do you take it on an empty stomach? Are there other medications that they shouldn't take that medication with because it could lead to drug interactions? Maybe they need to separate it from other drugs by several hours. So that's very important. Filling all of the prescriptions at the same pharmacy. Because our healthcare system is so fragmented, our primary care team, whether it's the inpatient or outpatient team, may not have a record of all the prescriptions, but if one pharmacy is filling all those medications, that gives that opportunity to that pharmacy to detect those problems when the patient has multiple different providers. That's probably some of the best advice that I think you can give patients is to tell them why it's important to fill all of their medications at the same pharmacy and to keep an updated list of all their medications with them at all times. That's especially helpful in emergent situations. I would say also being cautious with complementary and over-the-counter products. If they're not sure if they're going to interact with their prescription drugs, then they need to call and ask, whether it's the pharmacist or the provider or the nurse. They need to maintain a level of caution with those medications. Additionally, informing healthcare professionals about any OTC or CAMs, as I've already explained. Grapefruit juice is a food that I always would mention to patients. Grapefruit juice affects the metabolism of several drugs, as I've already mentioned. And so if the patient drinks grapefruit juice every day, even, like not even a whole lot, but if they drink it every single day, it can make a big difference. So they should be informed about that. Now, if they're not on a drug that's affected by grapefruit juice, they can certainly drink it. But they need to be cognizant of the fact that grapefruit juice is one of those foods that interacts with a lot of different medications. Limiting alcohol. Now, some medications that have CNS depressant properties, those can be especially dangerous with alcohol. But other medications can be problemsome as well. Alcohol can irritate the lining of the esophagus and stomach. So if the patient drinks a lot of alcohol and they're on aspirin or nonsteroidal drugs or oral bisphosphonates like Fosamax, that's used for treating osteoporosis, then drinking alcohol along with those medications can be a problem. So again, something you want to talk to your patients about. And then the last thing I would say is talk to the pharmacist. You don't hear me say that a lot in this course. The purpose of me being here and teaching this course is to make you guys as self-sufficient with administering and medications and educating patients on medications as possible. But, with drug interactions, there's just so much to know. And the pharmacist is an expert on drug interactions. So my advice for all of you is if you're uncomfortable, call the pharmacist, and they will, in most cases, gladly talk to you about drug interactions. Like I've already said, one of my most favorite things to talk about in the whole world, other than my kids, is drug interactions, because in pharmacy school we spend so much time learning about drug interactions and how to manage drug interactions that it's almost like a sense of pride with pharmacists. They want to be involved in the management of drug interactions, so don't hesitate to call your pharmacist. Furthermore, don't hesitate to tell patients to talk to the pharmacist. I think patients are pretty good about this, at least from my experience working in a community pharmacy, but nevertheless, tell them to go talk to the pharmacist, and the pharmacist will be happy in most scenarios to help them out. Okay, so I have a couple active learning activities. Let's go through a few sample test questions. All right, so which individual is at the highest risk for a drug interaction? A toddler who's prescribed an antibiotic for an infection, an adolescent who takes over-the-counter medications like NSAIDs for menstrual cramps, an adult who takes 8 prescription medications for a chronic condition, or an older adult who takes 2 medications and a dietary supplement for anxiety. So what do you guys think? Well, if you said answer C, then I would agree with you. Now, with that said, it doesn't mean that these other patients aren't also at risk, but I would say that the risk of serious interactions is proportional to the number of drugs the patient's taking. The likelihood of interactions is going to increase as the patient is on more and more medications. So that patient C probably is at the highest risk, although if, for patient D, if that patient was, on 2 prescription medications and a dietary supplement for anxiety, but then you told me that, one of the patient's conditions was AFib and he was on warfarin. Well, warfarin interacts with a lot of drugs. So it's always going to come back to what that interacting drug is. But just generally speaking, the more drugs you're on, the higher risk you have for drug interactions. Question 2. The nurse cares for a patient who's taking a calcium channel blocker for hypertension. The nurse should be most concerned if the patient makes which statement? By the way, calcium channel blockers are first-line therapy for hypertension as well as arrhythmias, as well as angina, and lots of other conditions. We're going to talk about these drugs a lot throughout this course. So this is just the first time I'm mentioning them, but we're going to talk about them a whole lot. So, responses: I take my medicine with a glass of water. I eat food high in fiber to prevent constipation. I drink a glass of grapefruit juice every night, or I avoid foods such as broccoli and cabbage. So, you guys probably know where I'm going with this. I've already mentioned that grapefruit juice is concerning, not with all meds, but it is concerning with some, and calcium channel blockers are one of those drug classes where grapefruit juice is a big problem. It inhibits the metabolism of the calcium channel blockers, and they will accumulate. And calcium channel blockers have direct effects on the heart, especially a couple of our calcium channel blockers. They can cause bradycardia, and that can progress to AV block. Especially in the setting of high drug levels. So grapefruit juice, big deal with calcium channel blockers. The last question is that a patient is prescribed a medication to be taken on an empty stomach. Which statement should the nurse include when providing patient teaching? Take the medication 1 hour before eating. Take the medication with a small glass of water. Take the medication before going to bed at night. Take the medication 1 hour after a meal. So the most appropriate answer here is A, take the medication 1 hour before eating, because that's the most broad statement. Generally, when we say take something on an empty stomach, we mean to take it at least an hour before eating. Now, does it mean that the patient might take the medication with water? Sure. That would be a totally fine answer, but on its own, that would not be the right answer. Does it mean that if the patient is taking this medication once a day, it's okay to take it at bedtime? Well, sure, it's okay to take it at bedtime, but what if they just ate 5 minutes prior? That would not be good. And then 1 hour after a meal. Generally, that's not the way we advise patients. What we say is 1 hour before a meal or 2 hours after a meal. So D is absolutely incorrect. Now, there's a lot of nuance to this question. So I probably, I should say Dr. Hudson and I probably wouldn't put something this nuanced on the exam. We don't try to trick you guys. We do put some of these nuanced questions in our practice just because we want to make sure you really are grasping the concepts, and that, in real life is nuanced. But I do think that we're pretty fair with our test questions. All right, so that's it. Thank you so much for listening. If you have any questions, please post them to the discussion board. Thank you.